Today, I am going to present a case of PDA device closure in less than 1 kg preterm infant. Now, this is a combined effort by Fortis Hospital, Anandapur and NSH Howrah, and I am presenting this case as a part of the team. This was a 24-day-old neonate who weighed 800 grams and was on CPAP support, had a large tubular hemodynamically significant PDA and severe unregressed neonatal pH. A little about the history. The baby was born at 26 weeks with a birth weight of 725 grams. PDA was detected on day 5. Several courses of pharmacotherapy were tried, but there was no response. The baby was not gaining weight, persistently oxygen dependent initially, and then required non-invasive ventilation. There was renal dysfunction, and the PDA was large, tubular, with severe pulmonary hypertension and features of congestive heart failure. If we look at the echocardiography, you will understand that this was a very large PDA which measured almost 4 millimeters at the narrowest point with significant left ventricular volume overload and pulmonary hypertension. Now, PDA device closure is quite a common procedure and with very minimal risk of complications. But PDA in a preterm baby is a different ballgame. This was our first case. I personally has done 3 or 4 PDA device closures in 1 to 2 kilo weight group, but not less than 1 kilo. Similar is the experience of my co-operators. So that was one of the obstacles. Prematurity and extremely low birth weight of the baby is definitely the most important factor. And another problem we faced was the hospital infrastructure. The baby was admitted in one hospital where there was good NICU setup, but the cath lab was not prepared for a neonatal intervention. Similarly, the other hospital where we did the case, that is NSH Howrah, has a cath lab where regular neonatal interventions are done, but they don't have a proper neonatal intensive care setup. So to overcome all these challenges, we made a team comprising of pediatric cardiologist, intensivist, anesthetist. We definitely had a surgical backup in case of any complications. And the whole procedure was supervised by the neonatologist. The procedure at the center where it was done had the maximum neonatal intervention experience in Kolkata, and the baby was kept out of NICU for minimum period. That's what we decided. This was our little angel weighing 820 grams 2 days after the procedure when the baby was extubated. To prepare, we shifted the baby to cath lab on the day of the procedure to minimize the exposure to out of the NICU. The baby was electively intubated and transported, and the cath lab was pre-warmed. The baby was positioned on a warm blanket with slightly extended neck, and the ECG and NIBP monitor was attached. The access was ultrasound guided because we are not very regularly doing ultrasound guidance. So we asked for the help from our pediatric intensivist colleague. And we got a right femoral venous access and we put a 4 French Terumo radiofocus sheath. Regarding the hardware part, we used 4 French glide catheter and 0.014 coronary wire and 032 Terumo wire. Device, we used 5x2 Amplatzer piccolo occluder and the delivery system was a 4 French Amplatzer TORQ FULP catheter. Now, Amplatzer piccolo occluder is the only device which is approved by FDA for use in such a small baby. It is approved in more than 700 grams. The advantage is it goes through the 4 French delivery system, and with venous approach only, it is possible to deliver. This is the guide for choosing the device size depending upon the internal diameter at the narrowest point and the length of the ductus. This was a tubular duct which was long and which measured about 6 millimeter at the aortic end, 4 millimeter at the pulmonary end, and length was about 9 millimeter. And according to the recommendation, we choose a 5x2 device, and the plan was to put the device within the PDA and to put it intraductally. This was the crossing the PDA, which was caused with a coronary wire using a 4 French glide catheter, which was kept at the IVCRA junction. The aortogram was done through the 4 French glide catheter with hand injection of 1 to 1.5 ml contrast. And this was the duct morphology, which was almost similar to what we have seen on the PDA, on the echocardiography. We did not measure the ductal length or the narrowest point on the angiogram. We decided about the device on echocardiographic measurement. This was the device deployment first attempt. You can see that the glide catheter has been exchanged with a Amplatzer TOG FEW LP catheter. And through that 4 French catheter, we are taking the 5x2 Amplatzer Piccolo occluder, and it is being positioned within the PDA. The landmarks here are the orogastric tube, which is positioned just posterior to the trachea. This is our posterior landmark, and we try to deliver the device just in front of this orogastric tube, but unfortunately the device slipped out, and you can notice that there is unusual traction on the cable, and that was the probable reason. So we decided to recross the PDA in the similar manner. We put a 034 or 032 terumo wire, and which was positioned distally into the left femoral artery to give adequate strength to the wire, and the delivery system was taken over this wire. And now you can see the device deployment. This was our second attempt. Similarly, we have taken the device under fluoroscopy guidance, and we were able to successfully position it just in front of the orogastric tube within the duct. And we confirmed the position by echocardiography. We did not do any angiogram after device deployment. After the release of the device, this is the X-ray where you can see the device is nicely positioned. The wire shifted immediately and sheet removed there. The periprocedural echocardiography plays a very important role. So we need to check that the device is placed within the duct, no significant residual flow. There is no obstruction to the aorta or the left pulmonary artery, no significant tricuspid regurgitation. This is the periprocedural echocardiography, and you can see that there is unobstructed flow in the aorta and the left pulmonary artery. There is mild ventricular dysfunction, which is quite expected, but there is no significant obstruction, and the device is nicely positioned without any residual flow. Periprocedural issues: there was low blood pressure. When we positioned the terumo catheter within the aorta after crossing through the PDA, we checked the invasive blood pressure, and accordingly we started adrenaline infusion. Initially, heparin was not given, but because the first attempt failed and we were taking slightly longer time, we decided to give 50 units of heparin. Post-procedure period, the baby required high ventilatory support. We did a chest X-ray which showed collapse of the right upper lobe, which was managed with left lateral position and optimized ventilation. The baby improved overnight and transported back to the NICU of referral hospital the very next morning and extubated. Subsequent course was quite smooth. There was no vascular compromise. Echocardiography showed moderate ventricular dysfunction, mild MR and AR. So we started on milrinone and stopped the adrenaline. The baby was discharged 1 month after the procedure, weighing 1.5 kg. This was the echocardiography on post-procedure day 2, and you can see that there is moderate ventricular dysfunction, but the device is nicely positioned, and it improved quickly after the baby was started on milrinone, and it was tapered off in 48 to 72 hours. And it was so. To conclude, this was our first experience, and this was the smallest baby. So technically, it is not a challenging procedure, but the challenge is the baby's weight and prematurity. So it needs proper planning and very efficient teamwork. Amplatzer Piccolo occluder is the only FDA-approved product for use in such a small baby. Another thing is very important, as in pediatrics, we say children are not small adults. Similarly, preterm neonates are not only small babies, they are a separate entity. And for that, they need special attention. Thank you to all the team members who helped us to do our first PDA device closure in such a small baby. And I will also thank everyone who are listening and the PCSI committee who have given me the opportunity to present in front of this learned audience. Thank you very much.
Thank you, Dr. Detar.